Wonderful. Okay, firstly, my apologies, I can't be there in person, but nonetheless, I've been listening to some of the wonderful talks today. But yeah, so this is my presentation on large language models in clinical advice. So there are a number of studies assessing healthcare professionals' perceptions of using large language models as a clinical decision support tool, and it showed that there is promise, but there need some extensive validations to build trust within those solutions. And large language models have problems with their use, and there's an audience here which I'm pretty sure that you guys are aware of the problems associated with large language models. But there was an online survey by the British Medical Journal where there were about 1,000 respondents, and 20% of general practitioners use large language models. 5% use large language models to even suggest differential diagnoses. ChatGPT was the large language model of choice. And there was another survey done by the Health Foundation, which showed that 76% of staff support the use of AI for patient care, and even 50% of the public. So when looking at retrieval augmented generation, for example, so we can hook up a large language model to a external knowledge source, which is known as retrieval augmented generation, to ameliorate some of the issues that we listed on the previous slide. And actually, it's a pretty good solution in clinical spaces, because healthcare professionals have argued for the use based on the evidence-based approach of clinical tasks. And retrieval augmented generation can actually give us kind of somewhat of an insight into how it's generating those answers. So dealing with the issue of explainability. So this diagram just shows its model after Fan et al., but it shows how a patient input question can be used to retrieve knowledge from an external knowledge source, which is then used to generate an answer. So with regards to retrieval, there's a number of different methods of retrieval, but for this study, we decided to use two due to the sake of time: the cosine similarity retrieval and cipher query retrieval. Cosine similarity retrieval, text converted into embeddings in vector space, and it's relatively inflexible. You have to set your parameters, the number of results that you retrieve, and the threshold of similarity that you want to use. Cipher querying, although is newer and more flexible, is a targeted approach, but it requires something known as a knowledge graph, which is a logical hierarchy of entities and their relationships. So looking at in the healthcare space, we want to be able to actually show how these things are useful. So how do we actually evaluate large language models? How can you quantify correctness? How do you incorporate nuances as answers in evaluation metrics? There's no real consensus on how to evaluate large language models in healthcare. There's no real regulatory guidance either for large language models. So I've listed a few studies here which show the different methods used, but they're not exhausted. So you can see the top there, Morat et al., they just categorized large language model outputs based on risk to patient safety. Binary et al. Used precision recall and F1 scores for LLMs in how they recommend treatment plans, etc. But there are some overarching themes. So subject matter experts use LLM, they scored those LLM generated answers against certain criteria and comparing it against reference materials. So well, we see Lee et al. And Tam et al., they outlined some frameworks which are useful in evaluating large language models. For this particular use case, for this particular study where we're evaluating large language models in healthcare space against specialists, we actually have access to something called the UK Medicines Information Guidance. And that guidance actually is used to assess the types of answers that medicines information specialists give to clinical queries. So that was really useful to implement in this study. And what do they do in industry? Well, there are a number of quantitative evaluation metrics that are used. So we wanted to also explore these. How can we correlate quantitative metrics to such a realm of how to quantify the correctness and safety of clinical answers? So there are a number of different methods that we use. Cosine similarity to see what's the semantic alignment. Is there anything useful that we can extract from cosine similarities between a reference answer and a LLM generated answer? BERT score, which builds upon cosine score, but it looks at more token level granular relationships. QNLI, question natural language inference, which looks to assess whether there's entailment of the answer based on the question proposed. And then finally, actually getting a large language model itself to evaluate the answers produced by a large language model. So methodology, we had access to a database, a medicines information database at Oxford University Hospitals, where patients and healthcare professionals ask questions to the pharmacy service, and they then have specialist trained pharmacists who perform literature reviews, literature searches, look at the question and provide an answer. So performed stratified randomized sampling to extract 53 questions initially, but that was reduced down to 24 due to evaluation time constraints. And I'll talk about that in a little while. These clinical queries that are asked of the service are separated out into about 3 different levels. Level 1s, which are fairly simple, straightforward questions. Something like, can I take ibuprofen with my naproxen medication? Or level 2 queries, which require a bit more in-depth searches, and level 3 queries, which are clinically high risk and require a lot more investigation. So we had those, and for this study, the 24 questions, picked 12 level 1 questions, 10 level 2, and 2 level 3 questions. That was a reflective proportional complexity of the questions encountered in clinical practice. And there were some exclusion criteria I should mention. So if any question or answer contained any patient identifiable information or any sensitive or reference any sensitive information, that was excluded. So when I mentioned that there were 2 different elements of retrieval that we decided to use, we needed to build a knowledge base for the cipher querying. So how this slide just shows a overview of how the knowledge base was created. So there are specific texts which are local protocols, so local guidelines for that may be the safe and effective use of medications in hospital. So you can see that in the top right hand corner. That medicines information leaflet contains a lot of important information, so we decided to include that within the knowledge graph. So that was scraped. Named entity recognition was used to extract names of any medications in that text. And then we use something called the summary of medicinal product characteristics, which are specific guidelines for medication. So in this scenario, for example, cabergoline, we have 1 milligram tablets, and that contains as SMPC contains important information about the absorption rate for that medication, or the interactions information about that, side effects, etc. So those were split out into different relationships and different nodes and entities. So, and on the left-hand side of the page, you can see how the hierarchical structure looked for this knowledge base. And it's important to realize that what we also did was to extract the text information from these different sections from the medicines information leaflet as well, and those were converted into embeddings and also placed in the knowledge graph. So it actually meant that we were able to use the knowledge graph for the cosine similarity retrieval as well as the cipher querying retrieval. So again, how did the evaluation take place? Well, we had 24 questions, and from the database, each separate question was fed into a different retrieval augmented large language model. So first off, we had the vanilla RAG, which is the cosine similarity retrieval. And second, we had graph RAG, which used cipher query retrieval. Third, we had a control, which was ChatGPT 4.0, which was used to generate answers without any contextual retrieval. However, the control method was there to ensure that the answer that was provided to the question asked of it was actually in line with hospital protocols and UK English, etc. So there were guidelines and context fed into ChatGPT 4.0. So there was prompt engineering involved. Lastly, there were the human reference answers that we had from the database. Those were standardized for grammar, tone, text, etc. So because these 4 answers were going to be graded by subject matter experts, we wanted to blind them to the type of question that's being answered. Sorry, the source of that answer. So there were no biases that could creep in during the evaluation process. So each of the 24 questions had 4 answers associated with it, and those the reference answers were compared against the generated answers for cosine similarity, CBERT, clinical BERT scores, and entailment. There was also subject matter experts, i.e. pharmacists, scored each answer for 4 criteria. Number 1, whether it addressed the proposed question. Number 2, whether it was accurate and correct. Number 3, does the answer pose a risk to patient safety? And number 4, was it produced by a human? 4 was there included just to see whether there were any biases in the evaluation process. And as you can see here, if each one question has 4 answers, and each of those 4 answers has 4 questions answers associated with it, that just blows up in the evaluation process. So in the end, we had somewhere close to 400 answers for the subject matter experts to address. So from this slide, we can see what the results look like. So for quantitative metrics, we see the cosine similarity, because the similarity scores for cosine were high across the board for all large language model generated answers compared to the reference text. And this is kind of expected because it measures broad semantic similarity. So there wasn't any statistically significant findings. Clinical BERT F1 scores, however, they were a bit more sensitive to differences in alignment between the reference and the generated answers. But again, there was nothing statistically significant that we can draw from the results. However, the heat map on the left-hand side, just behind the table, does show some value. We can see this heat map. This is token level alignments, token similarities between the reference text and the generated answers. And there are areas where you are able to tell that there's a strong similarity between the two. So the question natural language inference QNLI, we were able to see this measures entailment between the question and answer. So interestingly enough, there was quite a vanilla rag and graph rag showed quite similar distributions for their entailment, whereas ChatGPT 4.0 was was more varied, as well as the human reference answers. The human one is kind of expected because we found that the actual answers that the human professionals included within the text, they were actually they were recorded in retrospect. So there was a lot of context which was omitted. So which led to a broader distribution in the QNLI scores. So about the expert evaluation, results from the expert evaluation show that median scores are pretty much the same all across the board, although the box plots do differ between certain criterion models. Large language model medians from conducting the same exercise were marked as a black diamond, so you can see there. You notice that the large language model tended to score more towards the extremes and not take nuances into account. But when we looked at the Kruskal-Wallis test for these different criteria, we were able to see that there was statistically significant differences between the median scores for accuracy, risk, relevance in level 1 questions and level 2 and across all levels. Once we conducted the post-hoc Duns test, you can see that the statistically significant results are marked with an asterisk. But what I really want to do is draw your attention to the right-hand side. And for relevance at the top, ChatGPT 4.0 outperformed human reference answers for relevance. And that could be, again, due to the fact that the human reference answers were actually recorded in retrospect. So they lacked a lot of context. When humans are recording things in retrospect, they tend to write it in a rushed nature and just include the main specific points. Whereas when humans were expert human professionals were actually evaluating these results, they were looking at the holistic answer, and during the human reference answers, they weren't there. For accuracy, vanilla rag, i.e. cosine similarity, rag outperformed graph rag. And that's due to the fact that graph rag had a few retrieval issues due to obscure questions. There was a question about isosorbide mononitrate, which graph rag wasn't actually able to adequately answer. The cipher query returned the wrong formulations, and that was due to the fact that there was an arbitrary cutoff. Because of the limited context window, graph rag is able to retrieve all results, and the arbitrary cutoff for graph rag resulted in inaccurate retrieval. And risk, so the risk to patient safety, interestingly enough, vanilla rag, i.e. cosine similarity, outperformed human references and graph rag. So to conclude, large language models actually can achieve strong performance and even outperform expert humans when evaluated by pharmacy professionals. Even out of models have a strong performance. However, that should be with a pinch of salt, because the study relied on stringent controls for the ChatGPT 4.0 via the use of prompt engineering and guardrails. At the moment, there's no real regulations around the use of large language models in patient care. At the time of the study, there was nothing. It was a gray area. Right at this minute, the MHRA are looking into the use of large language models in healthcare applications in the NHS. There is a need for regulatory bodies to catch up to LLMs as they develop multimodal capabilities, and healthcare professionals are using them at the moment. And there's no consistent method of actually how to evaluate large language models. So thank you very much. If anyone